C. Roberts, who's come to us from the Baylor Medical Center in Dallas. For many, many years, Dr. Roberts was at the NIH, where I've enjoyed reading his articles, hypertrophic osteoarthritis, hypertrophic cardiomyopathy over the years, and I guess he wrote about osteoarthritis too. I don't know. I did enjoy his articles very much. He's currently the editor of the American Journal of Cardiology. He's been at Dallas about 18 months. He's a graduate of the Emory Medical School before going to NIH many years ago. He has a long interest in atherosclerosis. Today he's going to talk to us about the flip side a little bit, that is regression of atherosclerosis. And I want to welcome him to Scott and White, and look forward to your talk.
Well, thank you very much, Dr. Starr. It's a pleasure indeed to be here. I also want to thank Merck Sharp and Dome for making this visit possible. I've not been here before, and so it's really a treat to see this place, which is quite prominent not only in the state of Texas, obviously, but elsewhere. Go ahead with the first slide, if you would. I'm going to talk about, excuse me for showing this slide. When I was at NIH for all those many decades, I'd sort of get annoyed when people would show their pictures of their local institution, but since I'm in the business now, I've started showing where it is, particularly since there are two Baylors, not just one. Sorry, I hit the wrong button. Now, this is a coronary artery, and it's filled up with atherosclerotic plaques. Maybe you want to turn these lights out up here anyway. These slides will show up better. And what I'm going to focus on is the atherosclerotic plaque. How much narrowing does it cause in patients with symptomatic coronary disease? What do these plaques consist of? As you know, coronary atherosclerosis, or atherosclerosis in general, is an unbelievably common disease in the Western world. If you just look at that person next to you, one of you is going to die from atherosclerosis. Now, I know it's going to be the other one, not you, but nearly 50% of us in this country. Last year, this disease alone cost nearly $120 billion. Bypass alone last year was 1% of the gross national product of this nation. Not 1% of the health expenses, but 1% of the gross national product. And in my view, atherosclerosis is hereditary in 1 out of 500 people. The rest of us, we determine whether we're going to fill up our arteries with this stuff or whether we're not. This is a slide that shows some data accumulated in my lab when I was at NIH. And we studied a number of patients with fatal coronary disease through the years, nearly 900 from this study. And the reason I show this is a natural history of coronary disease. The average age of death in men is 60. The average age in women is 68. This is without bypass, without angioplasty. So many of you don't think 60 is the prime of life, but in my view, it is. And that's a young age, folks. Atherosclerosis is not limited to coronary arteries. You want your arteries to look like that? How would you like to be a red blood cell and have to float through that one time every minute? I'm going to ask 6 questions and try to answer them. Question 1 is, how much atherosclerosis is needed in the coronary arteries to cause myocardial ischemia? Now, of course, the answer to the question depends on the method used to try to answer it. I can tell you that a lot of atherosclerosis is present. People use the word lesion, here's a lesion, assuming that there are no lesions elsewhere. In my view, if you have a patient with symptomatic myocardial ischemia, you have lesions throughout the coronary system. There may be some lesions that are bigger than others, and those bigger lesions cause luminal narrowing, but there are lesions everywhere. Now, this is some data collected in a group of patients with acute myocardial infarction, which was fatal. And what was done at necropsy, these 4 major coronary arteries were taken off the heart intact, and they were divided into little bitty 5-millimeter segments. And a histologic section was prepared from each 5-millimeter segment. Now, that averaged about 55 per patient. And what was found was about 1/3 of the lengths of these arteries. That length is about 27 centimeters, so 1/3 of that is about 9 centimeters, were narrowed over 75% in cross-sectional area. Actually, about 2% was 100%, and the rest of that was between 76 and 95% in cross-sectional area. Now, I'm not talking about diameter reduction, the unit of angiography. I'm talking about cross-sectional area. And then another 1/3 approximately were narrowed 51 to 75%, and only about 5% of the segments even approached normal. And not a single one was normal, not a single one. Now, the same kind of data was accumulated in other subsets. This is based on study of a group of patients with unstable angina. If you ask the question, does one coronary subset have more narrowing than another? What is the answer to that question? Again, the answer is dependent on which method one uses to determine that. By angiography, there's no difference. By this histologic approach, there is a difference. And the unstable angina patients unquestionably have the most coronary narrowing of any subset we ever studied. Nearly half of the coronary tree was narrowed 76 to 100%. And all of these patients, this initial study was based on 22 patients. All of these patients had normal ejection fractions, normal cardiac indices, but the worst coronary narrowing of all. In other words, myocardial function is not proportional necessarily to degrees of coronary narrowing. This is one of my beefs with nuclear cardiology. This summarizes some of this data that's collected. These various subsets, nearly 6,500 5-millimeter sections studied, and about 35% of them were narrowed 76 to 100%. The patients with unstable angina had by far and away the most narrowing. So the answer to the question, how much atherosclerosis is necessary to cause at least fatal coronary disease, and I believe symptomatic, I don't think there's a lot of difference between amounts of narrowing in symptomatic myocardial ischemia versus fatal myocardial ischemia. Their answer is a whole lot. This is a montage of these little 5-millimeter segments in a patient with unstable angina. And just go down the right here and try to find a segment that's normal. Left main terribly narrowed, left anterior descending. Look at that. Now, if you're going to blow up a balloon, where would you blow it up? Here, 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 everywhere. Well, that little fellow right there is okay. Okay. Left circumflex abdominal artery here. Look at this, all the way out. Now, this is why I've become a preventive person. You can do an angioplasty on this person. You can do a bypass operation. But how many years are you going to add by this very expensive procedures? I show this simply to point out that what I've been talking about is cross-sectional area narrowing. And one of the physiologic principles, as I've been taught anyway, is that one has to have at least, at a minimum, 75% cross-sectional area narrowing in order to have any decreased flow through a pipe, through a tube, through a coronary artery. Now, in general, a 75% cross-sectional area narrowing is equivalent to a 50% diameter reduction. But that, a 50% diameter reduction in somebody with symptomatic myocardial ischemia assumes that you're comparing an area of narrowing to an adjacent area which is normal. And from the data I've already shown, how many segments were entirely normal? And the answer is virtually 0. So you're comparing an area of considerable narrowing to simply an area less narrow. If one asks the question, how much of the coronary tree, that is, of these 4 major arteries, if you just look at the lumen and say that the lumen of these 4 coronary arteries consists of this area, in the average patient with fatal coronary disease, about 2/3 of that lumen is filled up with plaque. Control group, similar age and sex, about 1/3. Question 2, what do the atherosclerotic plaques consist of? Anybody? Everybody knows what they consist of. What do they consist of? Foam cells. Foam cells. Anything else? Anybody? What? Lipids. Foam cells, lipids, what else? Calcium. Macrophages. Anything else? What's the dominant component of atherosclerotic plaques in patients with fatal coronary disease? Platelets? What? What? Clot? Platelets, clot, what else? Our most common disease is going to kill half of us in this room. What do these things consist of? What? What? Cholesterol. Okay. Well, this is a slide where we took a large group of patients with fatal coronary disease, and we looked at all these little 5-millimeter segments. And those which caused very little luminal narrowing, 25% or less, were put in this column. And those which caused virtual total occlusion were put in this column. And these are the various components of the atherosclerotic plaques. Now, these are patients with fatal coronary disease. The average age of death in these patients was 59, and all of the patients in this study were over age 40. The yellow represents dense fibrous tissue, which essentially is acellular. So here we have acellular fibrous tissue, and the red represents cellular fibrous tissue. And what this shows is, if you go from little plaques to big plaques, the amount of dense fibrous tissue increases, the amount of cellular fibrous tissue decreases. Calcium, which is blue, is really present only in the big plaques. The green represents pultaceous debris. And what in God's name is pultaceous debris? Well, that's extracellular lipid, and that's present only in the big plaques. Foam cells are very uncommon in people with fatal coronary disease over age 40. So the answer to the question that the dominant component of atherosclerotic plaques in patients with fatal coronary disease is not platelets, it's not thrombus, it's not calcium, it's not lipids, it's scar tissue, it's fibrous tissue. Now, this again is in patients with fatal coronary disease. These patients are not 10 years of age. Now, if one asks the question, is there any difference in composition of atherosclerotic plaques among the various coronary subsets? What is the answer? Yes or no? Do patients with acute myocardial infarction have the same kind of plaques as patients with unstable angina? Or those who have fatal cardiac arrest outside the hospital, they have the same kind of plaques? Well, we tried to answer that question by looking just at the big plaques for the moment. That is, those causing over 75% cross-sectional area narrowing. because it's only in the big plaques really where you get a good deal of variation. And what we found was the patients with acute myocardial infarction compared to sudden coronary death or unstable angina pectoris, these patients, and these all three bars here, these patients were over 40 years of age, average 59. They had a great deal more pultaceous debris, again extracellular lipid, than did these two subsets. We had a control group of women who died in their 30s from coronary events, and they had a lot of foam cells, but the average age of death there was 35. So the younger people do have some foam cells. After age 40, foam cells are very uncommon. Now, we're in the era of reversibility of plaques. You're looking at a patient with angina pectoris. You're making ward rounds in the coronary care unit and seeing this patient with acute myocardial infarction and this one another one. Now, can those plaques shrink? Does plaque reversibility really occur? And if so, which portions of these plaques are reversible? Is the dense fibrous tissue reversible? I think not. There's some evidence, possibly from Robert Whistler in Chicago, that some of the cellular fibrous tissue, believe it or not, is reversible. Calcium, I think everyone would agree that that's probably not reversible. This pultaceous debris here, this green, this lipid material, that is clearly, unequivocally reversible. So reversibility can occur, but the dominant component of the plaques, namely fibrous tissue, is plus or minus how much it can be dissolved. Question 3, how many direct atherosclerotic risk factors are there? What's the key word in that question? Direct. How many are there? 10? Adult Lipid Committee that's formulated all the indications for lipid-lowering therapy and so on. They say there are 10 atherosclerotic risk factors. How many do you say? How many direct atherosclerotic risk factors are there? Anybody? 1? 5. What 5? Hypertension. And you mean by direct that if you don't have hypertension, you can't get atherosclerosis? 1. Oh, you've changed your mind. They're 1. And which one would you choose? Hypercholesterolemia. And what is hypercholesterolemia to you? Anything over 200. Okay, you're talking about total. Well, which are you talking about? You talking about total, or are you talking about a ratio?
I'll go with the HDL to LDL ratio is the most important.
Most important. Okay. Now, if I have a total cholesterol of 300 and an HDL of 100, are you going to worry about me? You were going to worry about me?
I have to figure out your HDL. Your HDL.
My HDL is 100. My total is 300. Okay, I happen to agree with you, sir. As far as I'm concerned, there's one risk factor for atherosclerosis, one direct one. That is, if you don't have it, you don't get atherosclerosis. If your total cholesterol is 140, 130, 120, 148 for a lifetime, you don't have to worry about atherosclerosis. In my view, none of these are direct atherosclerotic risk factors. Now, if your total cholesterol is over 150, these things like high blood pressure, cigarette smoking are accelerators. They're adders on. But they, in and of themselves, are not direct atherosclerotic risk factors. Now, you might say, well, no, these patients that I see have total cholesterol 150. Well, what world are you in, fellow? Well, when we're born, our total cholesterol in umbilical blood is about 75, as I understand it. Within 2 weeks of life, it shoots up to about 150, and it stays about 150 until we graduate from high school, and then it gradually goes up. Now, if we could keep it what it was when we were 20, the health of this nation would skyrocket. And we determine that when we pull our chair up to the table 21 times a week. Our parents didn't determine that. They determined it at most in 1 out of 500 people. Some say 1 out of 200. The rest of us, we determine it. Now, what factors indicate that cholesterol causes atherosclerosis? Well, there are 6 factors in my view. It started back in 1908 by some Russian physiologists who fed high cholesterol diets to certain animals and produced atherosclerotic plaques similar to those in humans. Now, which animals did they choose? What do you say? Rabbits. Why'd they choose rabbits? You sure they chose rabbits?
No, I had to guess.
You get, what if they chose dogs? Can you produce atherosclerosis in a dog? Sure. Sure? Really? Can you produce atherosclerosis in a cat? Sure? Why not? Okay. So it doesn't really matter, is that right? Well, the answer is that you cannot produce atherosclerosis in a carnivore, period. The only way you can produce atherosclerosis in a dog or cat is first take out the thyroid gland and then give a high-fat, high-cholesterol diet, and you can do it. But if you're talking about a normal carnivore, you cannot produce atherosclerosis no matter how much fat and cholesterol you give. You can only produce atherosclerosis in an herbivore. Now I ask you, sir, if you give a human being enough fat and cholesterol, can you produce atherosclerosis? The answer is yes or no.
I'm a carnivore, so no.
You're a carnivore. We do good autopsies, too. Now, let me ask you this. The second thing was cholesterol is found in experimentally induced plaques and in those occurring naturally. The third bit of evidence was the international epidemiologic studies. Started by Ansel Keys. I consider him a great man after World War II, and I conclude from those studies this: atherosclerotic plaques large enough to produce clinical problems occur only in people having serum total cholesterol levels greater than 150. Now that's a very important item in my view. Items 4, 5, and 6 were solidified the last decade. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Item 5 cost us millions of dollars as taxpayers. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. And number 6, 5 studies on number 6 were published in 1990 and several since then. This is relatively new. Atherosclerotic plaques regress when high blood cholesterol levels are lowered. So in my view, the connection between cholesterol and plaques is a very firm one. It would hold up in any court in any land. Now, the cholesterol problem, as you well know in the USA, is an unbelievable one. This is data from the Lipid Research Clinic. And what it shows is the percent of the U.S. population with total cholesterol levels greater than 240. And what we see in women, for example, after age 55 in this country, about half the women, just these two lines, about half the women have total cholesterol levels greater than 240. Men, there's a higher frequency of high levels in men earlier in life. But after age 55, the percent of men with levels over 240 is less. And the reason I believe is because the men with the higher levels earlier in life are no longer with us to be able to be studied. But at any rate, cholesterol problem in the U.S. is a major one. Now this is Ansel Keys' famous 7-nation study. He went to these 7 countries, studied approximately 13,000 individuals, found that people in certain portions of Japan had a very low frequency of symptomatic coronary disease. Those in USA, Finland, a very high frequency. What did he find? That in Japan at that time, this was in the 60s, the total cholesterol was averaging about 150. In Finland, it was approaching 300. He concluded in the 60s that this was a cholesterol problem. This is a study from Stamler, 1986, the Mr. Fit study. I think it's a very important one because of the number of people examined. Over 350,000. They were all men, ladies, aged 35 to 57 when they entered the study. Excuse me. They were all asymptomatic. They were divided into 10 groups according to their serum total cholesterol level. And what we see as that level goes up, 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 and up, the coronary artery disease mortality, this should be over here, goes up, 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 and up. And that's only a 6-year mortality. It goes up much higher at 10 years, at 12 years, etc. No study, in my view, shows it better that that total cholesterol is a quantity. The higher the quantity, the greater the risk. Now, the Lipid Research Clinic study and the Helsinki Heart Study were primary prevention trials. Now, what that means, of course, is that one is studying a group of people who are asymptomatic, have never had clinical evidence of organ ischemia, and they have relatively high cholesterol levels, and they're given medicines or very stringent low-fat, low-cholesterol diet, or a ileal bypass operation, and cholesterol levels are lowered. But what those studies have shown is this, that if you lower one's total cholesterol by 10%, let's say from 200 to 180, that one decreases the chance of a heart attack by 30%. In other words, for every 1% reduction in that total cholesterol, you get a 3% decreased risk of heart attack. Now, unfortunately, the reverse is also true. If you raise total cholesterol by 10%, that is, let's say we go from 180 to 200, you increase your chance of a heart attack by 3 times that, 30%. Now, these are some of the secondary prevention studies which have been published. Now, secondary prevention, in contrast to primary prevention, of course, means that one is examining a group of people who've already had an atherosclerotic event. Most of these events were coronary events, myocardial infarction, and so on. Now, these studies here are absolutely overwhelming, in my view, showing the benefit of cholesterol lowering not only before an event, but after an event. These are angiographic results. Regression means the plaques have shrunk. The treatment group's in green, control group is in orange. And what do every one of these studies except the first one show? And that is the group of people who've had heart attacks and other events, when their cholesterol levels are lowered, the plaques shrink compared to the control group. And furthermore, and maybe even more important, the progression, that is plaques getting bigger, was much less in the treatment group compared to the control group. Now, in addition to evidences angiographically of change in plaque size, coronary event frequency also diminishes very significantly in people who've had one event and their cholesterol levels are lowered subsequently. Now, I ask you, at this institution, when somebody has a bypass operation, are they put on cholesterol-lowering agents? If somebody has angioplasty, are they put on cholesterol-lowering agents? If somebody has an acute myocardial infarction and they're healed, are they put on cholesterol-lowering agents? Or just aspirin and just beta blocker? Most cardiologists don't plug in lipid-lowering agents as standard procedure, and that's the way it ought to be in my view. Now, I don't have a monopoly on view there, of course, but it seems to me that the evidence for cholesterol lowering, not only after an event, but as well as before an event, is overwhelming. How many more studies are we going to have to make this a convincing thing? Now, this is what I conclude from these secondary prevention trials. If one has a coronary event, it means that one or more coronary arteries are narrowed greater than 75% in cross-sectional area. You can just bank on that. Now, if one has a person with the average total cholesterol of somebody with acute myocardial infarction is 225. If you have somebody with acute myocardial infarction and you can lower that level from 225 to 160, these plaques can be arrested, and those present can indeed shrink. The evidence for that now is overwhelming. So let's say we have an acute myocardial infarction and we reduce the lipid content of this plaque from here to here. We can open up that lumen so that it is now less than 75% narrowed rather than greater than 75% narrowed. And flow through this should be as if there's no plaque at all. In other words, small changes in plaque mass can be converted into very large changes in lumen size. Question 5. How can symptomatic atherosclerosis be prevented? And if present, how can it be arrested? How?
Lower the cholesterol.
Lower the cholesterol. Suppose it's already normal.
Prevent the fibrous scar from forming, or new fibrous scar from forming.
And how do you do that?
Research.
Research. Well, you got a patient in front of you. You going to tell him research?
I'll give them everything we have to offer, which is probably cholesterol-lowering agents.
Okay. How can symptomatic atherosclerosis be prevented, and if present, how can it be arrested? You were getting at it. If the cholesterol level is under 150, you just want to make sure it stays there. It doesn't go up. If it is elevated, you want to get it down. That's how atherosclerosis can be prevented. Number 6, how can normal cholesterol levels be prevented from rising, and how can elevated levels be lowered to normal? Now that's the rub. Well, the first thing we've got to do, in my view, is to keep our body weight down. I consider body weight a pretty good monitor. And whether you're a man or whether you're a woman, if you look at body weight here, the more we weigh, the sooner we die. We can all point to the Winston Churchills on the planet, but they're the exceptions. The more we weigh, the sooner we die. And in the USA, we're the fattest nation in the world. 60% of adults in the USA age 18 and over are overweight, and 30% frankly obese. The second thing we have to do is know how many calories we can consume each day or each week and maintain an ideal weight or one fairly close to that. Now, I'm 6 feet tall, 72 inches. My body weight, I don't like to get my weight over 170. So in my house, the scales, the good ones with a mast on them, are right next to the refrigerator. And if I get on those scales and I'm over 170, I just don't open that refrigerator door. But I think we all have to have a number that we're willing to live by. Now, +1 activity is very sedentary, and +4 is a marathon runner. So for me, I'm in between these two. So I try to limit my calories to about 2,500 a day. And you can buy these scales in any drugstore in the USA. But we need to know that so we can talk intelligently to patients. And women are the same. You need to know it. The third thing we have to do and this is obvious, is we have to decrease the amount of cholesterol we take in, and we have to decrease the amount of fat we take in. Now, cholesterol, as everyone knows, and most people know anyway, comes from animals or their products. So if we eliminate animals, we eliminate cholesterol. Half the cholesterol we take in comes from eggs, and about a third of the other comes from beef. So if we give up those two, we've really knocked a big hole in cholesterol. Now, most of us take in only about 400 or 500 milligrams of cholesterol every day. Now, how do you picture that? How do you talk to somebody about that? Well, I can tell you that a toothpick weighs 100 milligrams. So most of us take in only about 5 toothpicks of cholesterol every day. And if we give up those eggs, we give up at least 2 of those toothpicks. Now, in contrast to cholesterol, fat is a real problem, that 3-letter word. In the USA, most adults, and particularly here in Texas, average over 140 grams of fat every day. Now, a deck of cards weighs 75 grams. None of us should take in over 75 grams. Probably no man should take in over 60 grams, and no woman over 50 grams. Now, let's say you take in 120 grams in a day. The problem with fat is about a third of it, of course, is saturated. And when that saturated fat enters our bodies, it's converted into cholesterol. So our biggest source of cholesterol is not the direct stuff we bring in every day, but that which comes in through the saturated fat channel. Now, the next thing we have to do, of course, is decrease the percent of calories from fat. In the U.S., we're about 38, 39, or 40% of our calories from fat. And the American Heart Association, the most commonly prescribed diet in the USA by physicians, is 30% of our calories should come from fat. Now, if we knock our percent of calories from fat down by 25%, from 40% to 30%, what percent does that lower our total cholesterol level? What do you say? 5%. What do you say? 15. 15. 10. Ma'am? 15. The answer is 5%. It'll take you down from about 200 to 190. In other words, it's chicken feed. If we're going to lower cholesterol by diet, we must get the percent of calories from fat at least down to 20%. And then you get about a 20% reduction. But if you can't get it down to that much, you cause frustration in the patient and you cause frustration in the doctor. I recently went to another hospital to check some charts. I was asked to review some charts. And I noticed that of about the 60 charts I reviewed, these are people who had a bypass operation or angioplasty, that 57 of the 60 patients were prescribed a 30% of calories from fat diet when they were discharged from the hospital. When I was leaving the hospital, I saw one of the physicians who was writing those recommendations, and I asked him what percent of calories from fat did he eat every day. I said, "Oh gosh, I don't know if I've ever calculated that." He said, "As a matter of fact, I'm not sure how to calculate it." Well, if we're going to write these 30% of calories from fat diets, we need to know something about it, or we're going to get in trouble. Now, if you really want to get a good grease job in a hurry, there's no better place than the fast food industry. And what we see here are the ingredients of some of the hamburgers. The Carl's Jr. Double Western Bacon Cheeseburger, that's a coronary artery bypass special, folks. and is closely followed by Jack in the Box Ultimate Cheeseburger and Burger King Double Beef Whopper with cheese. We're talking about 1,000 calories approximately in those hamburgers. And if you take one of those suckers and squeeze it real hard, you can come up with about 15 teaspoons of fat in that single hamburger. And this little word here, sodium, it's not salt, it's not sodium chloride, it's sodium alone. And here we have 1,800 milligrams, 1,200, 1,200, 1,500. Whew. This fellow John Love wrote an interesting book on McDonald's. He called it McDonald's Behind the Arches. Bill Castelli, some of you probably heard him, he calls the arches of McDonald's the entrances into the pearly gates, and I think he's right. Look at this one. Slightly more than 50% of the population of the USA lives within 3 minutes of a McDonald's. McDonald's has employed at one time or another over 8 million workers, 7% of the entire U.S. workforce, and McDonald's has replaced the U.S. Army as America's largest job training organization. Folks, this is power. Tom Parker wrote a book entitled In One Day. He asked the question, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food are consumed every day. Roughly 200 billion more than we need. Those 200 billion left over would feed the whole country of Mexico every day, no problem. Nearly 100,000 cattle are slaughtered every day, yielding 60 million pounds of red meat. In the U.S., as you know, we have 260 million people and 100 million cows, and we kill 100,000 of them every day. And we do it differently here in Canada than in the rest of the world. We take these cows, as you know, they last 6 months of life and put them into these feedlots, and there feed them 20, 25 pounds of grain and soybean every day. And why do we do that? We do that, of course, to make them fat, because when they're fat, they taste better. And then we kill them, and then they kill us. And that's the way it works. Now, we also butcher about 250,000 hogs every day. Winston Churchill called them the smartest mammal. And we eat about 4 million pounds of bacon every day. Bacon's really the pits. It's about 85% pure fat. Now, if you don't know what it is, make a hot dog out of it. And we eat about 47 million of them every day. McDonald's puts 2,500 cows on their tables every day. Dairy cows yield 47 million gallons of milk every day. We eat 170 million eggs every day. And folks, if you're a chicken, don't wander into the USA. We kill about 12 million chickens every day. We eat about 50 million pounds of sugar, an average of 21 teaspoons apiece. Can you imagine waking up in the morning, looking at your bedside table, and seeing 21 teaspoons of sugar on your bedside table? These processed foods we all eat are loaded with sugar, and they're loaded with salt. We also eat about 3 million gallons of ice cream and 10 million pounds of candy every day. We drink 16 million gallons of beer and ale and 1.5 million gallons of hard liquor every day, enough to make 26 million Americans thoroughly drunk every day. We still have about 45 million cigarette smokers in the U.S., and we smoke about 85 million packs of cigarettes a day. I like this statement by William Collins. He says, the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog. Even when 100 grams of cholesterol, now that's 200 times the average daily intake of humans in the USA, plus 120 grams of butterfat are added to its meat ration. Adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. So are we more like the rabbit or more like the dog? Let's examine that a little closer. Here's some characteristics of carnivores and herbivores. Now, when you look down at your appendages, do you see claws, or do you see hands we're supposed to be using for gathering these fruits and vegetables we're supposed to be eating? Now, there are those who argue, like you do, sir, that the teeth in the front of our mouth are sharp, and so we're really omnivores. But most of our teeth are flat for grinding those fruits and vegetables. Now, the intestinal tract of a dog or cat's very short. You give them something to eat, they got to go outside in a few minutes to do their thing. But the small intestinal tract alone of a human being is 26 feet long. Plenty of time to extract those nutrients from the fruits and vegetables. Now, when you cool your body, do you pant like a dog or do you sweat? When you drink water, do you lap it like your cat or do you sip it? Vitamin C, the carnivores, they make it themselves. Herbivores, they have to obtain it from your diet. Do you make your own vitamin C? Well, if we could divide us in this room into two groups and put the pure vegetarians, one or two of us, I'm not a pure vegetarian, I eat fish still. If we put the pure vegetarians against that wall over there and the meat eaters over here and ask a simple question, what diseases do those pure vegetarians over there not get that these meat eaters over here get? Well, atherosclerosis is not a problem. Rarely get it. Systemic hypertension, high blood pressure, we have at least 60 million Americans with high blood pressure, but those vegetarians over there, they're not bothered by it. Certain cancers, cancer of the breast, most common cancer in women, very uncommon in vegetarians. Cancer of the colon, prostate gland, I saw an article recently, heavy meat eaters have much higher frequency of cancer of the prostate gland than light meat eaters. Diabetes mellitus after age 50 is just extremely uncommon in pure vegetarians. They're not obese, they're not bothered by peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, irritable bowel syndrome, hiatal hernia. Gastroenterologist, general surgeon be out of business if we were all pure vegetarians. They don't get gallstones, kidney stones, osteoarthritis, ladies, osteoporosis. Can we change our health? Of course we can. During World War II, as you know, during 1939 to 1945, there was not much red meat available, not much butter, and not much cheese, and not much milk around. And what happened to the cardiovascular death rate in certain countries? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. In the USA. Just kept on going up. This is a slide I took from the JMA a couple of years ago. It has to do with death rate from cancer of the breast. This is the amount of fat consumed by the average adult in these various countries around the world. And here we are, USA, about 140 grams of fat a day. We have one of the highest frequencies of cancer of the breast in the world. But this could be cancer of the colon. The lower the amount of fat consumed by any society, the lower the frequency of cancer of the colon. It could be high blood pressure. The lower the quantity of fat consumed by a society, the lower the blood pressure. And of course, it could be atherosclerosis. So by lowering the fat intake, we could make a huge dent in two of our most common cardiovascular conditions and two of the three most common cancers. Now, these lipid-lowering drugs, in my view, as already mentioned, I think all 7 million people approximately who have myocardial ischemia in this country should be on lipid-lowering drugs. Now, if they can get their percent of calories from fat down to 10%, like the Japanese have historically, the Japanese are now going up, these drugs might not be needed. But for the rest of us, unfortunately or fortunately, I think they will be needed. The statin drugs, once a day. The challenge is that 50% who start on these drugs, just like hypertension, quit taking them within a year. It's terrible. How do we sell people that this is for their health? And some people say, well, these drugs are too expensive, I can't afford them. Well, they seem to afford bypass operation. We spent about $9 billion. No, we spent I think about $9 billion last year on bypass. We spent about $4.5 billion on angioplasty. If we gave everybody with symptomatic myocardial ischemia one tablet of these statin drugs, it would cost max about $3 million. And I would think the benefit overall would be great. In my view, I mention again, in people who've already had an atherosclerotic event, the evidence is overwhelming that the lower the cholesterol level, the better. Now here's a coronary artery in someone who had angioplasty. Here's the lumen here, the balloon went off, pop, cracked the plaque. That's the way it works. A little dissection, I think that occurs in about everybody. This is a wonderful result, wonderful. But the plaque is still there. It's not going away. one can argue, well, the lipid-lowering drugs do not affect the frequency of restenosis. Well, maybe not. If you have a scar in your arm, it's going to heal. But they certainly prevent progression in areas where angioplasty was not done. And this is the saphenous vein. This saphenous vein in the last 5 years of this patient's life was not in the leg, but it was in the aortico-coronary position. And here we are 5 years later, the atherosclerotic plaque has filled up the saphenous vein. Bypass operation, angioplasty, is not enough in and of itself. The cholesterol levels have got to come down. This is one of the more important slides I could show. Let's say primary prevention, you're on this curve. If your total cholesterol level is 310 and you knock that down to 270, you decrease your risk of an atherosclerotic event in half. If you knock it from 270 to 230, you decrease it in half again. If you knock it from 230 to 190, you decrease it in half again. If you already had an atherosclerotic event, it shifts that line to the left, but nevertheless, one doesn't have to give up. If you go from 270 to 230, you decrease the chance of a subsequent event in half. If you go from 230 to 190, you decrease that chance again. Pays big dividends. I show this slide because this was the state of hypertension in this country back in 1972. For everybody with hypertension in 1972, only about 60 of them knew that they had it. 40 were not aware that they had hypertension. Of the 60 who knew they had hypertension, 30 were not seeing a doctor, and of the 30 seeing a doctor, only 15 were having that blood pressure adequately controlled. Now that was 1972. Now in 1994, this 15% is up to about 50%. Now suppose we substituted hypercholesterolemia for hypertension. I would suggest to you that this 15 would be 1. It's a bottomless pit out there, and we haven't even started on that yet. Now these are coronary arteries at sites of maximal narrowing in a woman who was 103 years of age. Look at these coronary arteries. This is the right one here. This was the biggest plaque in her body right there, but look at that lumen, wide open, 103 years of age. The reason I show it is to point out that atherosclerosis is not a degenerative disease. We don't have to get it just because we get older. We are the degenerates, I'm afraid, not this disease. I like Mark Twain's statement. He says, the only way to keep health is to eat what you don't want, drink what you don't like, and do what you'd rather not. William Dock, a very prominent physician in the past in this country, why do without the things we like to do without them longer? But it's up to each one of us. When we pull our chair up to that table, we determine our fate, and I'm absolutely convinced that we in this profession must set the example for those not in this profession, or they won't listen to us. Thank you very much. Thank you.
We'll stop now. You can come up and ask questions if you have any.
Okay.
Thank you very much.
Hey.